what I'm going to talk to you about, similar to Len's story, this has been a journey of mine in my interest and practice in surgical palliative care. And it also has risen now to the level of attention of the American College of Surgeons. The TQIP guidelines, best practices with respect to surgical palliative care, those are the newest TQIP guidelines, and you'll hear a little bit more tomorrow from Avery Nathans about the TQIP aspect. I'm going to talk to you about some strategies, some science about what we are learning about how to improve our practice of palliative care for surgical patients. So I have some, they're really more aims than objectives. I am going to talk about some science, what we have recently learned and what we are currently studying about how to improve care for our patients with life-threatening illness, and talk about some personal challenges in this area and share some of what I have learned going through these challenges. So this is the WHO definition of palliative care, and you will notice that in this definition, there is nothing about death. There is nothing about this is what you do for people who are dying. It talks about life-threatening illness for sure, but this is not something that is reserved for patients who are dying. It is for patients, including our surgical patients, and I would argue that many of our acute care surgical patients and many of our trauma patients, if not all of them, are facing life-threatening illness, are seriously ill if they're not terminally ill. There's another definition of surgical palliative care which talks specifically about the operations or procedures. And although these procedures may be familiar to many of you, particularly our head-injured patients that need some type of gastrostomy tube or tracheostomy, I'm not really going to focus on the specific procedures or that narrower definition of surgical palliative care, but talk really more about strategies. So one of the reasons this is a little more difficult for those of us who care for patients with surgical traumatic life-threatening illness is because it's a little longer than the 3 to 5 minutes that Dr. Jacobs talked about, but we have to do this relatively quickly. And this is not the same as providing palliative care to patients with a more medical illness. If you take cancer, the trajectory of the illness of cancer is a much longer trajectory, similar heart failure and dementia. That trajectory is much longer, so these principles and practices of palliative care are employed over a much longer period of time. So you get to know the patient, you get to know the family, you get to know all of the different providers who are providing care for that patient. You build relationships, and time is helpful in building and establishing those relationships. For traumatic injury, an unexpected death or an unexpected serious illness, an unexpected event, that trajectory is much shorter. And so the relationships that are built have to be built on in a much shorter time period, and because of that, they can be a lot more difficult. I'm going to talk a little bit about one of the first studies that established that palliative care was not just a nice thing to do. It is a nice thing to do. It's an important thing to do. Dr. Jacobs talked about spreading love and affection. That's part of palliative care. But this study has now been repeated in many different types of illness, and I picked this one because it is a surgical disease. So this is 150 patients with non-small cell lung cancer, and they were randomized to standard oncology care. And what that meant was, in addition to the chemotherapeutic agents, and any surgical procedures that were necessary, the patient and family met with a palliative care practitioner when it was requested. So some of these patients had palliative care. They might have met once, they might have met relatively routinely. Some of these patients did not have any interaction with the palliative care team. And the other group was randomized to integrated palliative care, and what that meant was within 3 months of their diagnosis, they met with a palliative care practitioner. Some of these practitioners were physician's assistants, some were nurse practitioners, and some were physicians. And then they met with them either in person or by phone or by teleconference every month thereafter. And the group that was investigating this was interested in two things. How long did each group live, and what was the quality of life? What was their quality of life during that time that they lived? And these are the two measures of quality of life. They're standardized measures, and in each of the boxes, you can see a gray line going across the middle. That was their baseline. And in each of the groups, the standardized patients, or the patients that were randomized to standard care, their quality of life went down from baseline. And in each of these scales, the quality of life for the patients that were randomized to the integrated palliative care arm went up. And for one of the subscales, it was statistically significant, and for one, it was not. And this is nice. Again, they have a better quality of life if they meet with a palliative care practitioner, a palliative care team, routinely during this life-threatening terminal disease. But what was really surprising, and again, it has been repeated in multiple disease states now and multiple surgical disease states now, is that they lived longer. They lived 2.5 months longer. And all that was happening was they were meeting with a palliative care team. Now, you may say 2.5 months is not a really big deal. And there are many diseases where we say, we subject patients to chemotherapy, we subject patients to long ICU stays, we spend a lot of money, and all we gain is 2.5 months, and is that really worth it? But they lived 2.5 months longer in a better quality of life. And all that we were doing was meeting with them on a monthly basis. So this got a lot of people's attention, and again, it has been repeated. But the big question is, why does this happen? It may be intuitive that that they live with a better quality of life, but why do they live longer? And this was controlled for age and stage of disease and gender and socioeconomic status. So the data are very solid. And some of the reasons that we think this happens is their symptoms are controlled, they have a lot of support, we communicate with them, and we're all taught to communicate now, no matter what type of training. We know that we need to have the patients ask questions, give room for the patients and families to ask questions. What that really looks like is we give the patients and families a little bit of information, and then we ask them, because we've been trained, we know how to do this, and then we start and we don't give them further opportunities. And that model really looks like tell, ask, and then give a lot more information. And the palliative care practitioners in this study started by asking, talked a little bit, asked a lot more, talked a little bit, asked a lot more. And so that model really looks more like ask, tell, ask. Tell, ask, tell, ask. A lot more asking, a lot more input, and giving the patients and families control. And it's really that aspect of control, the locus of control, that probably is at the base or at the root of the reasons for increased length of life as well as increased quality of life. So this is Donna. You may take care of a lot of Donnas in your practice as the population of the United States is aging. And Donna may look fairly healthy here, and she, for her age, is fairly healthy. But if Donna is injured, or if Donna undergoes a pretty major operation, it's not always clear to us how well Donna is going to do, and it's not always clear to us what Donna might want to happen if things don't go particularly well. So we, coming from the ICU aspect of caring for Donna and many Donnas, not knowing what they would have wanted, we started audio taping Donna and Donna's cohort in clinic with surgeons who were offering high-risk operations, trying to get at what the conversation was like before Donna ended up in the intensive care unit with complications after a major operation. And these are some of the transcripts that we saw. If we're going to be there, then we have a verbal contract that we're going to do everything we can to have the outcome that we want. So if we're going to go forward with that, then we have an understanding that everybody is going to do their utmost. And Donna says, you do what you have to do. Well, I don't know about you, but as the intensivist now caring for Donna, this tells me nothing about what Donna would want. And it doesn't really tell me that she and her surgeon had a conversation that was meaningful. But they clearly had a conversation, and they believed that they had an understanding. This is another one. Sometimes it turns into a war, and you have to fight battles to win the war, and you have to be prepared for that on some level. Well, that's God's will. I've led a good life. Again, this is not very helpful understanding Donna, understanding what Donna knows about what might happen, and it highlights a theme that came through in many of these conversations, that patients are perfectly happy, many of them, particularly of Donna's age, to die in the operating room. And all of us know that most deaths after traumatic injury, most deaths after elective operation don't happen in the operating room. They happen in the intensive care unit after multiple interventions and multiple days and weeks. So there are lots of checklists out there now. And the work that we did with buy-in has led to what we call a question prompt list. And unlike some of the checklists, some of the question lists that are out there that are given to patients and families, suggested to ask before operations, how many of these has your surgeon done? Is your hospital a specialized center? This list is directed toward the patient and trying to get them to think about what they might want and what they're trying to get out of the conversation. So right now at 5 centers around the country, we are mailing this question prompt list to patients that have an appointment with a surgeon in 2 weeks before the appointment, to try to get patients to think about this while they're at home, while they're having dinner with their family, where they might be ready to have a conversation that was a little more informed than the snippets of 2 previous conversations that I showed. We don't know what the result is. As I said, this study is ongoing, and by the end of the year, we'll have about 350 patients and audio tapes from those conversations to see if the conversations are materially different than the conversations we have audio recorded at this point. This is one of the tools that I think is helpful in palliative care, and if you think about it, it really is upstream from where most palliative care is practiced. It's prior to the event that initiates much of surgical palliative care. So this is one of Donna's counterparts. As you see, this patient is not as healthy as Donna is. He is quite frail, however you measure frailty. And frail patients who undergo an operation or who have a major traumatic injury have a complication rate of over 50%. And so not only is measuring frailty important, but having conversations with these patients becomes particularly important, and translating the information that we know about this percentage, the percentage likelihood that they might die, the percentage that they might have specific complications, translating that information into information that the patient and family can understand is extremely important, and I think part of good palliative care. And the tool that I'm going to share with you or describe is called Best Case, Worst Case. And it's a tool to have the conversation, to do the communicating that is so important in palliative care. So treatment one on the left, surgery. This could be an elective surgical operation. This could be tracheostomy and gastrostomy in someone with a significant head injury. It could just be further aggressive care. And treatment two is supportive care. The stars at the top are the best case. The squares at the bottom are the worst case. And the ovals are in the middle are the most likely outcome. And I will step through this with you as to how this works. What is important about this is on a piece of paper that the patient and family can take with them, and it gets a snapshot of this gets put in the medical record, so the entire care team has this to refer to. So this is a situation where there's a traumatic brain injury, there's a complication that's occurred, so you are conveying bad news to a family member, unlikely a patient in at least this outlined scenario. And this was a demonstration for somebody with toxic megacolon who already had multiple organ failure. So the options were total colectomy or comfort care, describing the best case, worst case, and most likely. So it's outlined here. These are the two options going forward to care for this patient. And so this is where the numbers that many of us use in our day-to-day communication with patients, this is where that communication strategy is significantly different from best case, worst case. So rather than giving those numbers, and you also can see these numbers in the ACS risk calculator, rather than giving those numbers to patients and families, you integrate those numbers to give a most likely outcome for the patient and family. So 20% chance of renal failure, 35% chance of stroke. You give that into a most likely outcome because it is, it's been demonstrated that the ability of any of us to integrate the percentages that we give patients and families is just not there. And to give them a story or a description is much more effective in conveying what their life is going to be like after the intervention or the recommended course of action that you give. So once you've made that integration, you talked with the patient or family about what their values and goals are. So if you think it is likely that they're going to be discharged to a skilled nursing facility, if you think it's likely that they're going to have the need for dialysis, and you find out that neither of those things are acceptable to the patient, that then gives you the ability to make a recommendation based on the patient's values and goals. This is what you might describe. You might think this is acceptable, not acceptable, but once you understand what the patient's values and goals are, you can then make a recommendation for either an aggressive approach or comfort care. So I'm going to switch gears a little bit and talk about a case. This is a case that many of us may have taken care of. 82-year-old in a motor vehicle collision, has rib fractures, no head injury, a splenic injury, and a pelvic fracture. And as things go, you provide optimal care, pain control, good pulmonary toilet, and not surprisingly, this patient in the next 36 to 48 hours has increasing respiratory distress, is hypoxic, retracting, and I don't know if any of you have ever been hypoxic, but it is incredibly uncomfortable and scary. And almost without fail, if you ask this patient at this time what they want you to do for them, they want you to take that hypoxia away, anything that you will do, even if it is not consistent with their prior goals of care. So the time to have this conversation with this patient is not now. The time to have the conversation with this patient is when they come in, before they get to the point that they are hypoxic. Because this is what's likely to happen, and then you're stuck without knowing the patient's goals, without knowing the patient's desires. So one way to do this is to use a palliative care bundle. Assess this every day. It's not, it's not rocket science. It's just good communication and good patient care. Another way to help with this is to have routine family meetings. In the medical realm, routine family meetings are suggested based on diagnosis. So there are diagnoses that are likely to lead to a terminal outcome. In the surgical world, it is not as predictable to be diagnosis-based, but more time-based. Anybody that has a 3-day or longer stay in the intensive care unit is likely to have a non-home discharge, is likely to require significant help and therapy after. And interventions that may not be consistent with their goals of care. So to wrap up with some of my personal challenges, not all patients, not all surgeons, not all physicians are as ready to discuss palliative care, to discuss potentially limiting care, and that readiness can come at different times. One of my favorite phrases is, well, I already told them that. You may have told them that. They haven't heard it. It means you need to tell them again. It means you need to tell them in a different way until they've heard it. Everybody brings biases to the table. The surgeons bring biases because of the buy-in phenomenon. Presence is incredibly important, and using presence and communication to diffuse conflict between different practitioners in the intensive care unit. And it's also important to recognize that there are changing frames of reference. And this is one of my mentors in palliative care uses the Matador and the bull in the ring analogy. So there are several players at a bullfight. There's the bull, there's the Matador, there are all of the spectators. And your view of this bull and your view of what you might do if faced with this bull is different if you're the Matador, if you're the man in purple just watching, knowing that this bull can't hurt you. And so it is very easy to expound and theorize about what your values are and what you would do with this bull who is charging, knowing you will never be there. And if you are one of the first responders who might have to go and stop the bleed, your view is significantly altered, or might be significantly altered. So it is, it's important to understand as a palliative care practitioner, as an intensivist, as someone providing good medical care, that you don't know what that perspective is going to be, and you need to allow that people can change their mind if they all of a sudden find themselves facing that bull up close. So this is the old model of palliative care. It pitted those of us who were trying to save lives against those who were providing palliative care. And we were trying to push the palliative and hospice care closer to death because we were winning the war in the life-prolonging care as life-prolonging care practitioners. A more appropriate model, a better model of care, is that palliative care is provided almost from the time of diagnosis. That does not pit people against each other, it does not use war analogies, and it's really the best strategy for our patients. So in order to improve surgical palliative care, the AZTrACC communication framework works best. Routine family meetings, potentially use of a question prompt list. We'll find out sometime in the next few years whether that actually works from a scientific standpoint. The best case, worst case communication framework, collaborative care, and understanding that people will be ready at different times, and that the timeline that is the most important is the patient's and family's timeline, not our timeline. So hopefully you are convinced that palliative care is not just end-of-life care. It can actually increase both length and quality of life. Surgical palliation can be consistent with goals of care, but is not always. And it's about communication. Yes, really, it's about communication. And there is a lot more that we need to understand about communication to provide tools for those who it may not come naturally to. And palliative care is not just end-of-life care, it is synonymous with good surgical care. Again, I thank you for your attention, and I would be happy to take any questions.